try to make it somewhat valuable for your time. Today we're going to talk about acute coronary syndrome and particularly STEMIs and how to evaluate a STEMI. And you might say, well, we already do that. How come we're doing it? Well, because we've had last month of the probably 20 or so STEMIs that were called to the hospital, to the receiving hospital, which is Peace Health Southwest. They had at least 5 of those that they determined were not STEMIs, or actually they weren't. They determined they did not take them to the cath lab. And so for the hospital's concept, they feel that that's a false STEMI activation. And of course, during the day, it's not an issue so much because the cath lab and everybody's there running. They're running a minimum of 2 cath labs any time. But at nighttime, they have to call in the crew, and it's, arguably it's about between $1,500 and $2,000 to do a crew call in. So, it's not a huge amount of money when you're into the concept of medical economics, but it involves and to me it's a point of pride, because they say, well, your medics are miscalling STEMIs. Well, we're going to make sure that that's not the case, but we did find out the most common cause. We looked at the most common cause of false STEMI activation in the last 24 months, and it is still left bundle branch block. So there is a point to all this. Now, but I'll also go through, we have some, I think, very good cases to discuss at the end, and they were determined not to go to the cath lab, and I'm going to give you the follow-up and also my interpretation of the 12 lead. And Marty is here too, so Dr. Bell, so he can back up how it works for the emergency physicians as well. So, talking about acute coronary syndrome, well, this is not STEMI. STEMI is part of the acute coronary syndrome, but acute coronary syndrome is exactly that, coronary artery disease and manifesting in some sort of symptomatology. And the symptoms are generally, classically we say chest pain and diaphoresis and things like that. Now, it is important that we quickly identify the actual STEMIs, because we inform the cath lab, get them rapidly to the cath lab, and take them in and try to open up that blocked artery and then stent it to keep it open. It's important in ACS for you to determine the time of the symptom onset, activate the hospital-based STEMI if we have a STEMI, monitor vital signs and cardiac rhythm, and be prepared to provide CPR, because we have a whole bunch of cases where you're looking at the STEMI and we're transporting the case and the patient goes into cardiac arrest. Theoretically, that's the best time to have a cardiac arrest. When you're on a monitor with someone who can do CPR and has a rapid and can rapidly apply defibrillation, because generally people go into a fibrillation arrest. Obviously, there are appropriate medication we'll talk about, and then to the appropriate facility. All STEMIs and high suspicion ACS cases should go to Peace Health Southwest, which is where we can take them to the cath lab. Now, who do we include in ACS? Classically, chest pain or discomfort, heaviness, a discomfort. A lot of people say, no, it doesn't really hurt, but I have a pressure in my chest. It can be in another part of the body. I've diagnosed acute MIs on people with epigastric pain, with low abdominal pain, even with groin pain, which is very odd. I didn't know where their heart was. Jaw pain, neck pain, pain between the shoulder blades. So, sometimes short of breath, diaphoresis, sweatiness. We used to say a patient who was diaphoretic, that was highly on my radar as being an ACS kind of patient. Vomiting, dizziness, weakness, lightheadedness, sort of, now, you need to put your interpretation of what's going on in the context of the patient. So a 45-year-old guy with a family history of MI, a family history of cardiac disease, and crushing substernal chest pain, nausea, and diaphoresis, that's very highly suspicious in my book for an ACS / STEMI. Now, put it in context of a 84-year-old woman in a nursing facility who's somewhat confused on a normal basis and now is diaphoretic and not responding normally to it, has a normal temperature, that might be suspicious for me for being sepsis or an MI, a coronary syndrome. So you have to, there's no complaint of chest pain here, but it's something different than usual. So those cases, I would do a 12 lead. Now, if you have a febrile, now not responsive, same little old lady in a nursing home, and she's febrile, and you walk in the room and it smells like urinary tract infection, I'm not automatically going to think that that's a coronary syndrome. Now, when you put a 12 lead on, be careful interpreting that then, because, in context, why, she may have some ST7 depression of ischemia, she may have some minor elevation, she may be in chronic atrial fibrillation with wide complex, it makes everything look different. So don't automatically call that a STEMI if you see that. Hey, you've got to put this, you have to contextualize what you see. That's what experience does for you. Now, some patients with an MI present with congestive heart failure. So sudden onset congestive heart failure with hypertension or hypotension, get a 12 lead on that, because that patient may have had a big anterolateral MI, sudden onset. They may present in frank cardiogenic shock. Obviously, though, or frank shock, those people deserve to have a 12 lead. Now, your assess, treat, interventions. So, symptoms of chest pain, congestive failure, syncope, shock, etc. Symptoms that are suspicious for coronary disease. Assess, monitor for specific dysrhythms. Obviously, you're more worried about them going into a VFib. Your O2 targets are 94 to 98. The 12 lead is your primary diagnostic tool to identify a STEMI, also to identify ischemia. And it's important that you routinely acquire the 12 lead in 10 minutes of arrival at the scene. When you suspect ACS, matter of fact, I'd rather see it, you know, in 5 minutes if you can do it. And then the first 12 lead is often non-diagnostic, and you need to repeat it. So serial 12 leads are the rule. My poster children for serial 12 leads is Camus, who does more serial 12 leads than anybody. I think they must have a deal on a special deal on paper out there, being that the mill, you know, does it, you know. But they do a lot of 12, and they have a bit more time than some areas to get to the. So I would like to see serial 12 leads anytime there's a change in chest pain or not a change in chest pain. So every 5 minutes would be reasonable if it's a normal. Now, you don't have to necessarily repeat it every 5 minutes if you've got a diagnostic STEMI the first time. Now, all patients get aspirin except whom? What's the one thing in our orders that say you don't give aspirin? Why? Or two things, actually. Allergy, known allergy to it, and you ask them if they're allergic to aspirin or to NSAIDs in general, and if they have a known acute GI bleed. IV access, 12 lead, advanced hospital notification for STEMI, and then serial 12 leads. Nitroglycerin, if the blood pressure is greater than 100, and this is not an inferior MI, because we don't want to drop what? Their preload, which drops their blood pressure. If you can't give them nitro, and if the nitro isn't, or in the case where you can give them, and nitro isn't helping, analgesia. And the analgesic of choice for us is fentanyl, because fentanyl will not materially affect their blood pressure, will not drop their preload, and it doesn't cause as much nausea, and it doesn't release histamine like morphine. Obviously, watch them for signs of deterioration, which is more chest pain, more shortness of breath, development congestive failure, decreased LOC, syncope, etc. Poor perfusion, hypotension. Serial 12 leads. Remember that in the elderly, people over 76, acute coronary syndrome may present with atypical chest pain, atypical pains, or just generalized malaise, generalized complaints, fatigue, not feeling right. Try to get a complete medication list on all patients. So, how to read a 12 lead. Now, we're trying to give the down and dirty, not the really finely tuned things. We want the stuff that'll get you through the night, get you through those emergencies, and be 98%, cover 98%, the helicopter on the roof now or something, 98% accurate. Now, so I'm not going to spend a lot of time talking about Scarbosa criterias and odd things like that. We want to do the basics first, and you jump from the you learn to run after you learn to walk. You'll read a 12 lead. You start out the same way, and people fail to do this. Start with rate and rhythm. You say, well, that's not really a 12 lead. I could get that off of a rhythm strip. Well, yeah, you could, but you look at rate and rhythm first. Then you should look at axis. Now, I'm going to tell you the simple way is to look at axis. It's not the super cardiology way, and I'll tell you why you should look at axis, because it will help you in a couple of things. But don't spend a lot of time on axis. QRS duration, you want to see what the QRS looks like. If it's greater than 0.12, it's wide. Now that means that 0.11 and maybe right up to zero, you know, I mean, when you're trying to measure on a 12 lead, you're going to be off by like 0.001, not uncommonly. So sometimes 0.12 is wide, and sometimes 0.12 is not quite wide enough. Once again, it's in context. Morphology, look at what does the QRS look like. And then we're going to talk about mimickers of STEMIs and STEMI. So, rate and rhythm. Is it fast, slow, normal? Is it regular or irregular? Remember, irregular, most of your irregular rhythms are going to be, or that make any difference, are going to be atrial fib. Irregularly irregular is always atrial fib until proven otherwise. It's the big mimicker of everything, and it will mess up your, because atrial fib also is highly associated with aberrant conduction. So you get you get left bundle branch patterns, sometimes right bundle branch patterns, but mostly left bundle branch patterns. Supraventricular or ventricular. So wide complex equals ventricular until you can prove otherwise. You're always safer to deal with it as being VTAC. Now, the big holdback is atrial fibrillation with aberrant conduction, wide complex. It's probably fooling you at that point. It's not VTAC. VTAC should be regular. That's why you look at the rate and the rhythm to start with. Axis. Now, what do you want to know about axis? Well, you can write this down. Left axis, I'm going to talk about axis after we tell you why you would look at it. Left axis deviation might suggest an anterior fascicular block. So the anterior fascicle of the bundle branches, of the left bundle branch. So the anterior fascicle, that anterior part, that might have a part, and that's what used to come up on your 12 lead. It says incomplete left bundle branch block. That was really a left fascicular block. They don't do that anymore. They sometimes say an anterior fascicle block, but they usually don't say. They usually say something like partial bundle branch block. This also might be from an inferior MI. So if you're trying to figure out if this is an inferior MI, if you're pushing the edge and it turns out that you say, well, this is left axis deviation, it may be. Paced rhythms almost always have left axis deviation because the way the pacer stimulates the bundle branches one after the other. Now, so left axis, think anterior fascicular block, incomplete left bundle branch block, anterior MI, or a paced rhythm. A right axis deviation would be suggestive of left posterior fascicular block, a lateral MI, right ventricular hypertrophy. Now that when would you see left ventricular hypertrophy? Somebody has chronic pulmonary disease or acute right-sided strain. So you might see that in a PE. So you'd see right axis deviation in a PE. So if you're leaning toward a PE because somebody's got, you know, your 12 lead doesn't show a STEMI, but the guy's got shortness of breath and chest discomfort and right heart strain, I would start thinking about a PE. Is there extreme axis deviation, what's called right superior axis? That's more suggestive of ventricular tachycardia, electrolytes derangements, including potassium, hyperkalium, or misplaced limb leads. Now, hopefully you figured out misplaced limb leads already at that point. Okay, so now you remember a couple things there, and then we talk about the simple way of looking at axis. And this is not, the cardiologist will say, no, you've got to do a lot more things. No, I'm going to have you look at just two leads all the time. Look at lead 1 and lead AVF. And your normal for, I need my pointer. Where's my pointer? Let's see, is there a pointer on this? Yep. You got me. Okay. Right side lower, normal. In those leads, 1 and AVF are both going up. The majority of the QRS is a strong is an upward deflection. It doesn't make any difference if it's a bundle branch block and you have 2 little deflections or not. It goes up. The majority of it is up. Left axis deviation, you've up in 1 and down in AVF. Then right axis deviation is just the reverse. Down in 1, up in F. And extreme right, so V tach, down in 1 and primarily down in AVF. And axis is all over and done with. You can scan it and just look, and we'll do that in a couple of 12 leads as we get into this. Next thing, once you're done with axis, look at your QRS duration, your normal intervals. So your normal QRS is up to 0.12 wide. And then you have the QT interval. Now, QT interval used to be a lot more difficult, and then they came up with QTC. QTC is the QT corrected. What did they correct it for? Heart rate. So the machine does it for you. So you don't have to mess around. You don't have to do, because it used to be impossible with a tachycardia to figure out, is this a prolonged QT or not? Now the machine will figure it out, and the algorithm is pretty accurate. So in this case, it's printing out that the QTC is, well, the QTC is the only one you really need to look at, and it says 0.47. And the QTC on men should be less than 450 milliseconds. Well, this one's a little bit more, 474, so it's a prolonged QT. So what do we care about the QT? If you prolong the QT interval, you're more likely to go into to have dysrhythms, PVCs, and VTAC, because prolonging the classic prolongation of your QT interval is the production of torsades. So drugs that prolong the QT are prone to dysrhythms, specifically VTAC and torsades. Drugs that prolong the QT are things like tricyclics, things like Haldol, etc., but it takes a lot of Haldol to do that, so don't get too excited. But that's why we have you put a monitor on patients who you've given Haldol to. It used to be a napsine, and can't get a napsine now, except for Cliff. And then amiodarone prolongs the QT interval. So that's why it works. That's why it works to some in preventing someone who's normalized, who's having PVCs or VTAC. We think it works on that, but if you have a really prolonged, it can also cause dysrhythms. It can cause torsades. So that's why I like you, if you know that someone's got a prolonged QT interval because they're in torsades, go to lidocaine instead of amiodarone for the drug, because lidocaine doesn't prolong the QT interval. Why would you give a QT prolonged patient more QT prolongation? Makes no sense to me. Oh, women, by the way, your normal QTC is a little bit longer, 460. So if this was a woman, this would still be a little bit too long. You say, well, what am I going to do with that prolonged QT interval? Well, I'm just going to watch it and be aware that that patient may develop PVCs, may develop VTAC. Morphology. If the QRS is wide, all you need to do is check V1. If it's wide, you're trying to rule out bundle branch blocks. A right bundle branch block has a terminal R wave. What that means is the last wave in your QRS complex is strongly upright. It's rightward. It's upward. The R is positive. So left bundle branch block may have a small R wave, but it always has a deep S wave. It may just have a deep Q wave looking thing. It may not have, you know, the S wave is totally prominent. You don't see an R wave. Wide complex, downward deflection. That's a left bundle branch block. For you guys, you don't have to look at anything else. Now, there are other things you can look at, but to give you confirmation. So here's your right bundle branch block types of morphologies. But if you look, in each of those cases, you've got a large upright deflection, which is a right bundle branch block. And when you see the nice little double rabbit ear kind of thing, you say, oh, for sure that's a bundle branch block, and it's upright in V1, so it's got to be a right bundle branch block. Left bundle branch block, just the opposite, a deep R wave. Now they showed what makes you feel really nice when you see it. Look at V6, the opposite side, and now you see an upright with a little rabbit ear thing. That's totally confirmatory. But you don't have to have that. You may just have the downward deflection, the big S wave, as you do in the second example. Sometimes in a left bundle branch block, you'll see a nice double-notched rabbit ear upright in 1, which is the same as the V6 lead. Remember, they're lateral leads, so they're really the same. V6 is a contiguous lead to lead 1. We'll get to that in a second. So, STEMI mimickers, discuss it in a bit. And how do you diagnose STEMI? 1 millimeter elevation, ST elevation, in 2 or more contiguous leads. They need to have symptoms of ACS. If you look at this little old guy, I don't want him coming, the other one besides left bundle branch blocks, which get called, is somebody who's on a pacemaker. Well, by definition, that's a left bundle branch block, usually. Because the left bundle gets stimulated after the right bundle. So, they gotta have symptoms of chest pain or congestive failure or something that makes you think, yeah, this is really a STEMI. It's not a STEMI, you know, and I think you're safer never to call a STEMI on a left bundle branch block, except for a couple of cases which we'll actually show you. Now, are there reciprocal changes? That's always a nice way of seeing that, yeah, this is really it. So if you have changes in the reciprocal lead, so if you have evidence of lateral ST segment elevation, is there inferior depression and inversion or just depression of T waves? So how does a myocardial infarction give us a STEMI? What is the evolution? What is this? Can you find me a pointer? He's a pointer, yeah. Okay. A is normal. You can believe that, right? So.
You guys see A up here?
Yeah, I guess you get what you pay for. I like to pay what he's worth, but you know, there are federal laws about that sort of thing. So, B, as you start having acute coronary syndrome, as you start getting ischemic events from a closure of a coronary artery, you develop hyperacute T waves. They get bigger, wider. Sometimes they peak, but not like they look kind of peak, but not like the T waves of hyperkalemia, which are really sharp and peak. They're mostly just big T waves, and you may start to see a slight elevation of the ST segment, usually not more than 1 millimeter or so. As this progresses, as you have occlusion and it progresses, then you start getting your extreme ST elevation, and it's now moved up and into that T wave. The T wave is still tall and wide, but it's now moved into it. As this progresses, as you move along, in D, you begin to develop a Q wave. Q wave is pathological. A truly pathological Q wave is several millimeters deep and fairly wide. So the Q wave begins to develop, and at that point your ST elevation is still there. So this we're talking now as the Q wave. To develop a Q wave, you probably need 12 to 24 hours. During that time period, the T wave starts to invert. It sort of has a biphasic wave, and it begins to, and your ST segment is still up, but maybe not as high as it was before the Q waves did. So it's developing. After several days, you now have a Q wave. So in D, you now have a Q wave. Usually, now that means there's dead tissue. A Q wave means we failed we failed to get him or her to the cath lab in time to stent that vessel. You've got dead tissue. That's what the Q wave means.
Sorry, you didn't have instructions.
No. Oh, there we go. Okay, so Q wave, now the ST segment has come back just about to normal or normal. You still have an inverted T wave. So this is probably in the first week. You know, most MIs, if you miss them, you get the Q wave, you get fairly normalized ST segment within about 7 days. And then from that point on, there's always going to be a Q wave there. And then the ST segment literally comes back to normal. Now, remember, where do you measure the ST segment? You don't measure it against the T wave, you measure it against the baseline, your baseline. Your baseline is where, you know, where the P wave is, basically. So across the baseline, that you draw your line across there. So this one, right, and so this is just about normal. Maybe slightly depressed, but that's, you know, neither here nor there at that point. But from that point on, that person's always got a Q wave. But notice that the ST segment literally comes back to normal. The T wave looks normal afterwards if you survive the MI, and you've got a Q wave. So put that in mind, because one of the mimickers still has elevated ST segments. You're going to see elevated ST segment when you're developing that. Now, what we are hoping for is that we get somebody who looks like this. We take them to the cath lab, and they end up looking like this when they get done. Because you open, you know, if you get them before they've got dead tissue, you don't have a Q wave, you have a normal ST segment. Now, there was a nice session before this in Vancouver Fire. You guys should start being aware of the sessions that Vancouver Fire has before this. So they did a nice anatomical presentation using the pair on where your leads tell you the MI is. But we don't have the time to go into that right now, so we'll just tell you which leads you look at for inferior MIs. So inferior MI is at the bottom of your heart, generally provided. Now, remember, the 12 lead is for all intents and purposes looking mostly at the left ventricle. When we talk about MIs, we're talking about left ventricle mostly, right? Because it's the big muscle, and it overwhelms the right side electrically with all the vectors and all this sort of stuff, all your electrical impulse, because you've got big muscle, little muscle. Remember, the left ventricle is putting out systolic pressure, you know, 120, 180, whatever the systolic. It's got a lot of muscle. The right heart is lazy. It's a little itty bitty wimpish muscle compared to the left ventricle. It only has to generate on a normal day 25 to 35 millimeters of pressure. Pulmonary system's low pressure system. Normal day, normally. So because the right heart is so weak, and it's just puny, it needs to have blood in order to make that pump. it doesn't squeeze very hard, and it has to be, it's stimulated by having a full ventricle, so it needs preload. It needs venous flow coming back into the right ventricle in order to help it work. So, an inferior MI, we're looking at the bottom of the left heart for all intents and purposes. And you just have to know that the left heart is sometimes, the inferior wall is sometimes fed by the left coronary system and sometimes fed by the right coronary system. And the right coronary system also feeds the right ventricle. So if you have a clot, an occlusion of the right coronary artery, you will have you sometimes will have an inferior MI, and sometimes that means that the right ventricle's also had an infarct, or is about to have an infarct, because it's a right coronary occlusion. Sometimes when you see an inferior and you check the right ventricle, you find out that no, the inferior wall is entirely supplied by the left coronary system. So the right ventricle is spared. So that's why we have you do extra things for this one. So an inferior, you see it in leads 2, 3, and AVF. The reciprocals of 2, 3, and AVF is 1 and AVL, the lateral side. You know, what do you see in reciprocals? You see, instead of ST segment elevation, you see depression, which sometimes is interpreted as ischemia, but it's really just it's a reciprocal thing. 1 in AVL and V5 and V6 are your lateral leads. 1 in AVL is called high lateral, and 1 and V5 and V6 are lateral. Those are supplied essentially by the circumflex artery, which is a branch of the left coronary. You have two main branches of the left coronary. You have the left anterior descending, which we call the LAD, the LAD, and then the circumflex. Then your true anterior, which is the main part of the left ventricle you're looking at, camera's looking at that. Your main is V1, V2, V3, V4. V1 and sometimes V2 are commonly thought as septal, because the left anterior descending supplies a lot of the blood to the septum. And that's why when you get a left anterior descending, you will often get a fascicular block. Remember, you're looking at your left axis deviation, and you will get some problems with the AV node, because it's supplied often by that. V2, V3, V4 are the classic anterior leads. So that'll show up mostly for your anterior infarct. Now you can have varying degrees of these involved, so you can get an anterolateral STEMI, you can get just a lateral STEMI. Remember, you need what? 2 contiguous leads. So V6 and 1 would be contiguous leads for lateral. It's almost, you almost never see that, but you usually see much more of those together. Posterior, now posterior infarcts are entirely, because there's nothing, there's really nothing facing that. You only see reciprocal changes. And you see, so V1, V2, V3, V4 might show you, it might show you ST segment depression and inversion. That could be a true posterior. That could be a posterior infarct. It's very uncommon, and generally, which saves you having to make any decision about that, is you also will see an inferior infarct associated with that. So, here's an inferior MI with changes in 2, 3, and AVF. And that also has already got some Q waves in it, so I'm a little bit worried about that one. This is not one that we saw, so, but this is the classic facing for now. What do you want to do for me now? How do you know that this is or is not a right coronary occlusion, a right ventricle infarct? 2, 3, and AVF, what do I want you to do? You want to do a V4R. Actually, I'd love for you to do a V3, V4R. Because with 2 leads, you'll pick up at least another 5% of posterior, right ventricular infarcts. So, you only have to do it once, and you don't have to do a V3, V4R if you've got an anterior infarct or if you've got a lateral infarct, unless you have an infralateral, which can occur. Anytime you have inferior, so 2, 3, AVF, and you only need 2 of those leads, by the way. It could be 2 and 3. More than likely, it's going to be 2 and AVF. That's what usually happens, but usually they're all together, which makes you feel real good. And you see, you notice nice reciprocal changes in 1 and AVL. Get those. So get a V3, V4R. You only have to do it once. You don't have to do it in any other infarct. You've got an inferior. And what do you want to do that for? You want to do it so that you can prove it. Then you can be aware that this person may have, if they have a right-sided infarct, they may start having some SA node issues, pacemaker type issues, because that's supplied by the right coronary usually. And they're going to be very sensitive to preload issues, so you don't want to vasodilate them, so you don't probably want to give them nitro, or give it very cautiously if they've got a normal blood pressure. Now, if you have a right-sided MI and the person has a pressure of 180 over 100, I'm not going to get too excited about that. I'd like you to drop their pressure a little bit. That's probably not good for them. Now, that's usually going to, so the usual thing is they've got a pressure of 100 to 120, and you'd have to be very cautious. I would use something else. I would use some fentanyl for their pain at that point. Don't forget the aspirin too. Okay, an anteroseptal MI. Anterior septal, remember they're going to be, you're looking at V1 through V2 usually. Anterior is going to be V2, V3, V4. So all your ST segment changes will be in those leads. So you'll have ST segment elevation. What if you see ST segment depression in those leads? And if the guy is presenting in chest pain, and he's a little diaphoretic, I would treat him just like give him his aspirin, give him his nitro, and get another 12 lead in 5 minutes. This may be, your ischemic changes are the the non-STEMIs, the non-ST segment things, and they may evolve. That may be your first sign, and we've got a couple of good cases in the past, don't have any today, that presented with ischemic type changes in the anterior leads, and then went on to classic ST segment elevation within 1 or 2 12 leads. We used to teach, it's not probably as accurate as that now, but we used to teach that at least 60% of your 12 leads were normal on the first 12 lead, if people called you with the onset of chest pain. So here's an here's an anterior MI, pure anterior MI without any changes in V1, so it's not a anteroseptal, it's just an anterior. This is actually an anterolateral because you have changes in all the way up to V4, and you say, well, those look pretty normal in 5 and 6, but look at 1 in AVF or AVL. Marked elevation, ST segment elevation. So that's your high lateral and anterior. You can tell me exactly then what vessels are involved, or probably. Say maybe you got 2 vessels involved in this one. You've got some occlusion and narrowing in the circumflex, in the far end of the circumflex, and you've got narrowing in the LAD. Or, so, this one may have multi-vessel disease. Needs two stents, or needs a coronary artery bypass. Another example of a anterolateral with ST segment elevations all the way out through V6. Also in AVL and 1, so this is a classic anterolateral. That probably has occlusion almost at the bifurcation of the, at the bifurcation of the left coronary, where it bifurcates into the left anterior descending and the circumflex. High lateral, involving only these. So, for a STEMI, you're looking for ST segment elevation greater than 1 millimeter in 2 contiguous leads. You just have to remember where your leads are. Have a pocket. If you can't remember these things, if you don't remember, have a pocket card, have something you can pop up on your thing, and you can tell me, we don't ask you to tell us what coronary artery is involved, but tell us if this is a inferior, a lateral, an anterior MI, a STEMI. So this is what your pocket cards normally look like. It breaks it down into fairly easy segments. STEMIs. Remember, we're looking for ST segment elevation of at least 1 millimeter in 2 contiguous leads. Now, some places want to have, some medical directors want you to have 2 millimeters in the anterior leads, and I don't go for that. I say just 1 millimeter, 2 contiguous leads, and then we're going to look for the mimickers. Acute pericarditis. Now, acute pericarditis, the guy will be complaining of chest pain. Usually it's younger persons. Pericarditis is often caused by viral things or post-viral. And you will have ST elevation in most leads, except AVR, which of course you normally should have ST inversion, but ST elevation in most leads and no reciprocal depression. Now, we were talking in the session before this session, and theoretically, it is possible, theoretically, if you have a left dominant coronary system, so that you have a teeny little, almost non-functional right coronary artery, and you were to get a large occlusion of the proximal portion of the left coronary, theoretically, then you could get ST segment elevation in every lead. That is so theoretical that I will forgive anybody, including myself, if you don't think about that when you see ST segment elevation in most leads, because it generally means if you're going to have an MI in every lead, that means you're probably going to be dead. So, but acute pericarditis, you have ST segment elevation in inferior, in anterior, and in lateral, and you think, well, that doesn't make any sense. And no, it doesn't make any sense unless you talk about pericarditis. Pericarditis is generally, the pain is not typical of a crushing substernal chest pain. It's pain in the chest, it's inflammatory pain, and it's often worse when they swallow, it's often worse if they lean forward. And so you think, well, it's inflammation that you're moving around. It's not ischemic pain, it's inflammatory pain. So put it in context of the thing. So when you see ST segment elevation, most of the places, young person thinks probably pericarditis. Left ventricular hypertrophy. Now this is really confusing when you've got wider complexes too, but left ventricular hypertrophy will commonly have ST segment elevation, and you think, well, ooh, my goodness, but these are really big R-wave deflections, and S-wave deflections, and the rule is if you put V1, the S wave of V1 together with the R wave of V5, if it's more than 35 millimeters, that's by definition left ventricular hypertrophy. And the alternative is V2, the S wave in V2 with the R wave in V6. If it's more than 35 millimeters, that's left ventricular hypertrophy. And the machine will often tell you there's left ventricular hypertrophy there. You should see left heart strain as well. And the axis on this one is purely, you notice this guy, the axis is purely normal, so that's pretty common. So, but left ventricular hypertrophy is one of the big mimickers. You can't count ST segment elevation then. Put it in cut. Now, if the guy has got crushing substernal chest pain, left ventricular hypertrophy, and symptoms that make you think ACS, call it in as, I've got a guy with chest pain, diaphoresis, I think it's acute coronary syndrome, we've got evidence of left ventricular hypertrophy, I can't call it a STEMI yet. Okay, we'll let us sort it out. Also, young, healthy people may look like have left ventricular hypertrophy, a so-called juvenile heart, an athlete. It's just because and really skinny people often, like children, will have pronounced R waves and S waves, because their chest wall is thin. That's why cardiologists, adult cardiologists say, "Oh, I can't read this. This is a juvenile pattern." Well, no, you can read it. You know, an adult is just a juvenile heart that's survived the pediatricians. Okay. Now, how about right bundle branch blocks? In a right bundle branch block, the STT changes are not affected by the right bundle branch block. So if you see a right bundle branch block, as you do here, we have a right bundle branch block, big terminal R wave, remember, V1? That's all I want, all we're gonna look at is V1. It has a little bit of inversion, but you go across the chest and now you start seeing some ST segment elevations. Oh, so this is an anterior MI, anterior STEMI with a right bundle branch block, but the right bundle branch block doesn't affect your ST segment elevation. So right bundle branch block, you can read MI in. The nice thing, most of the time your machine will tell you right bundle. Now, I keep referring to the machine, but I want you to always overread the machine, because the machine is wrong 40% of the time about its final diagnosis. It's not wrong about some of those things. It'll tell you the QTC. It'll tell you usually if you've got a bundle branch block. It'll tell you if you've got a fascicular block or a partial block. But don't trust it for telling you it'll tell you there's it meets ST elevation criteria. Sometimes yes, sometimes no. You read it. I'm worried more when it doesn't read it, and it's there. It usually screws up on atrial fibrillation. Sometimes identifies it, sometimes doesn't. So, always overread. But you can read right bundle branch block, acute ST segment elevation. So, here's another one. Right bundle branch block, and you've got ST segment elevation, and you get some changes in this one as it goes along. So, and this machine did all sorts of things. Oh, notice, what's the axis on this one, just for grins and giggles? You've got, it's up, and AVF is down. Left. Left bundle branch block. Okay. Widen QRS greater than 0.12, and it's a downward deflection in V1, and all bets are off on ST segment elevation, except, well, we'll look at this. So you've got a nice left bundle branch block, well, right here, and you've got ST segment elevation in these guys, this guy. Any rate, you've got ST segment elevation. You can say, well, gosh, is this an inferior MI? Well, or is it a V1 here, and you've got ST segment, so is it an anterior MI? No, it's a left bundle branch block. And this, the only thing, so this is the only part of Scarbosa criteria. First of all, you can't spell it. You can barely pronounce it. And the only important thing is the term discordance. Discordance is normal in left bundle branch block, which means the ST segment is in the opposite direction of the majority of the QRS. And to have ST segment elevation of concordance, you mean that the ST segment is elevated in the same lead that you have upright QRS complex. So you have to have elevated ST and you have to have upright QRS to be concordant. That's the only Scarborough criteria I ever wants you to. Normally, there are total discordance. For example, this is V1, and you have ST segment elevation. Okay. But the QRS is downward. There's no concordance there. Now you go across all these things. Every time you find an ST segment that's elevated, it's a downward going QRS. Now I have a great case later on which will show the difference. Normally, and so if for example in lead 3 we had, well, right here you have upright QRS in lead 2, but basically the ST segment is not elevated, it's down actually. This one you have upright, you definitely have a downward QRS, so that's not ST segment elevation. That's discordant. That's normal in left bundle branch block. Now, if you have concordance, you can call me or you can say, hey, I'm going to call this one a STEMI. And we'll wait till we get to that good case. Benign early repolarization. Young, healthy persons, athletes or not, but young and healthy, you get mild but widespread ST elevation, most prominent in V2, V3, often, sometimes in AV in the inferior leads. Sometimes you get notching and slurring at the J point. So this one, actually lead 3 shows it best. There's a little, the J point here, you get a little notch. This one has a little notch there too. But generally upright things, and you have to put it in the context of the patient the same way. But this is just moderate ST elevation, and you think why would this otherwise normal person be having an MI? That's your first question, and then say, well, it's elevated in all sorts of different leads. It's probably just a normal juvenile pattern. Ventricular aneurysm. Okay, after you have an MI, you may have, you got an area of dead tissue. It's still somewhat elastic, but it begins to develop a bleb. Just a ballooning outward of that weak spot in the ventricle. That bleb, that weak spot, is dyskinetic. It means it doesn't contract. So when the ventricle contracts, the bleb pushes out like any balloon would. You know, fill it with air or water, and you squeeze it and it pops outward. That's associated by EKG changes with persistent ST segment elevation, often in V1 and V4, because that's the anterior, the big part of the heart. But it can occur in any lead. So they have to have a past history of an infarct, a full STEMI, transmural STEMI. Transmural means the infarct goes all the way through the ventricle. That's an ST segment elevation and myocardial infarct that was or wasn't treated. And then remotely, let's say a month, 2 months after the incident, they still have ST segment elevation, but they also have evidence of big Q waves. So they've had a Q wave infarct, and their ST segment should have come back to normal, especially after a couple months, but now it hasn't, and because it's dyskinetic, and that's how it shows up on the 12 lead. That is not a STEMI. So you have to put that into, contextualize it with the patient history. Now, I'm not gonna, these are not STEMIs, but these are somewhat STEMI. These can confuse you as far as STEMIs. So, because atrial flutter, usually it's a reentry circuit. The rate at the atrium is 250 to 350, 360, and then your actual ventricular rate depends on, there's usually a block there, because, you know, if you, most of us can't sustain a heart rate of 360 to 300 to 360. So the AV node blocks it down. And when you block it down, when you block down at the AV node to a rate of anything from usually 150 is a good average, you may get aberrant conduction. And so it may look wide, and because it's beating so fast, you may get ischemic changes. So you see ischemic changes on your 12 lead as well. So this could look like, you could interpret that top one as being ischemic changes, T wave depression, ST depression, but it's just rate related. Now, atrial fibrillation is really, really common. The incidence is about 25% of people over the age of 40 will at some point develop atrial fibrillation. So as we're getting a relatively older population, we see a lot of atrial fibrillation. And of course, you know their atrial fibrillation when you look at their history and you ask them what medication they're on. They're always on Coumadin or one of the newer anticoagulants like Pradaxa or Eliquis, and a couple of heart medications. But always think, you know, just ask them, why are you taking this when you see that as a drug? And then you look at your 12 lead or your monitor leads, and you're going to have atrial fibrillation. Disorganized atrial activity, and it's usually running at about, averages also about 300. And so you get variable amounts through. It can be paroxysmal, come and go, can be chronic, may or may not be rate controlled. We have and it's very commonly associated with aberrant conduction because it's going down alternative pathways at the level of the AV node. It commonly occurs post-cardiac surgery. And this is a typical AFib. And you can see you have fairly wide complex, looks almost left bundly branch kind of thing. It may not quite measure out that much. You don't have any changes in V6, which would give you confirmatory, but clearly it's atrial fibrillation. It's irregularly irregular. You can't identify distinct P waves, If you have to lie about the P waves, they're not there. And you could argue, say, well, gosh, there's ST segment elevation there. Well, probably not. You can't bet anything with this kind of aberrant wide complex. Now, what you want to do, if there is change them now. If they're chronically in AFib, that's why you ask them a history. If you're chronically in AFib, unless they're in acute distress or unstable, their blood pressure's low, they're in failure, that you don't want to try to cardiovert them, because unless they're fully anticoagulated, if they're already on Eliquis, Pradaxa, that might be okay. Because people who have new onset within the last week or so atrial fibrillation, if they're not anticoagulated and you cardiovert them, they may throw a clot and stroke, which is not a good deal. If they're chronically on atrial fibrillation and they're chronically on an anticoagulant and they're in extremis, congestive failure, severe chest pain, their rate is 180, you could consider cardiovert them. Otherwise, we do rate control. And rate control normally is done for atrial fibrillation with something like a calcium channel blocker, or in the ER, a beta blocker, but usually a calcium channel blocker, except when you have wide complexes. Wide complexes, your orders will say, don't use calcium channel blocker. If you need a rate control agent, go to amiodarone at that point for wide complex. Okay, paroxysmal supraventricular tachycardia is the same thing. They may give you wide complexes that look like ventricular complexes, that may also look like left bundle branch complexes, and the same cautions hold for that. Ventricular tachycardia, and this one is arguably not just plain simple ventricular tachycardia, but a what? This is a torsades. If you get one like that, that's all. I mean, that's perfect. Most of the torsades don't look so cute. Rates greater than 120, QRS is greater than 120, AV dissociation, if you can even find a P wave. And if it's monomorphic, it's one thing. If it's polymorphic like this, then you can treat it as a torsades. Wide complex tachycardias, which are not clear in your mind what they are. The QRS is greater than 120, and the differential is ventricular tachycardia or SVT with aberrancy or a pacemaker rhythm. You should be able to determine whether someone has a pacemaker by history and physical exam. You should also be able to find pacemaker spikes. So we can put that one out. There are no perfect distinguishing things between SVT with aberrancy and VTAC, but you can bet on a couple things. History. In ventricular tachycardia, there's no past history of tachycardia. Most of the people you see who have a symptomatic SVT with aberrancy will give you history that they've had runs of rapid heart rate before. So if they don't have that history, it supports VTAC. If they have a history of structural cardiac disease, in other words, they have a valve problem, or they have they've already had a pacemaker problem, or they've had coronary artery surgery, that leans toward a VTAC. if they already have a pacemaker or an ICD in place, obviously. That's a historical thing. In supraventricular tachycardia, they will have a history of previous episodes. And usually by that time they know they've got supraventricular tachycardia. They'll tell you they've got Wolff Parkinson White or they've got something. And then exam. VTAC, more likely to be unstable, severely unstable. Cardiac failure, they may already have a sternotomy scar, a pacemaker, an ICD, etc. EKG findings, VTAC more commonly. VTAC is more common generally, about 80%, but up to 95% is more likely VTAC in people who are known to have ischemic heart disease. So if they've got a past history of coronary artery disease, they're likely to have VTAC. More likely with extreme right axis. So down in AVF, QRS. SVT, more likely with a rate that's exactly 150. So paroxysmal atrial flutter. And a complex that's not quite as wide, so moderately wide, 0.12 to 0.14. Okay. Chest pain, acute coronary syndrome by your protocol. Universal patient care protocol, oxygen to obtain SpO2 of 94 to 98, 12 lead AKG, and you can do that while you're doing other things. We talked this morning, one of the things I mentioned is that sometimes we get a disparity between the pre-hospital 12 lead and the hospital 12 lead, which appears to be attributed to position of the patient and position of your leads. Make sure that you put your lead, V1, chest leads goes on the fourth intercostal space. So you have to be able to accurately find the fourth intercostal space, and I always teach people to go for the angle of Lewis, the mid-radium sternal junction, which is at the second intercostal space, and just go down 2. So just be sure about your placement, and I'm fine with having with training the EMTs to help us do that. Just spend enough time with them so you're comfortable that that if they do put it on, that you're comfortable with them doing that. Aspirin, and per the cardiologist, they wanted 4 baby aspirin. There's no difference, but cardiologists wanted it, so I'll give them 4 baby aspirin. There's no difference in the studies between 2 and 4. So contraindicated and known allergy, active bleeding ulcer, severe liver failure, or severe systemic disease. Well, you're pretty well screwed anyway at that point. If the systolic blood pressure is greater than 110, your orders say nitroglycerin 0.4 milligrams or nitro spray. Anybody getting nitro spray anymore? Okay, it's that's kind of a hard one to do because nitro spray per the manufacturer is supposed to be used on 1 patient only. Well, obviously we don't do it that way because it's expensive. It's expensive, and but they say because you stick it in in their mouth and you say, oh my God, we're contaminating it. We don't let them lick the bottle. Yeah. Caution in right-sided MI we talked about. Contraindicated in patient taking phosphodiesterase inhibitors, so Viagra, Cialis, Levitra, sildenafil, which is the brand name of, which is the base of Viagra, within the past 48 hours. It doesn't make any difference which one they're taking. So just ask them if they're taking any of those. They may lie to you. That happens. Fentanyl for pain, if they're not responding to the nitro, or if you can't give them nitro. If hypotensive, follow shock protocol. To the extent that you may, if they're in true cardiac shock, we may have to give them a pressor. If they're not in, the first thing to do in shock protocol is to give them fluids. Well, lay them down and then give them fluids. If they're not in fulminant failure, pressors then. STEMI, early response protocol, if you think this is ACS and they're having a STEMI, active chest pain with or symptoms within less than 12 hours, 12 lead EKG, has ST elevation of a millimeter or more in at least 2 contiguous leads. If they have ST segment depression, you can say, ACS, I suspect a non-STEMI, an NSTEMI. You can't call it in as a STEMI, but tell the hospital you're coming in with a person with chest pain, you suspect ACS, and they're having ST segment depressions in the inferior leads, and get a serial 12 lead. No left bundle branch block or paced rhythm, except if you've got a left bundle branch block with concordance in 1 or more leads, and we're going to hit a good case on that. Notify ED of acute MI. Every transport agency is sending this 12 lead now by the Pulsera system. So the ED doc gets to see it, the 12 lead. So, but you can trigger the STEMI protocol. So they get all their normal treatment, transport emergently to the cath lab for probable cath lab thing. If the initial 12 lead is inconclusive or negative, repeat every 3 to 5 minutes as needed. If it indicates an inferior MI, I want a V3R and V4R. You're always remembering to do a V4. Let's try to get some V3s in there too. Doesn't take any more time to stick 2 things on. Okay. Now somewhere here I have cases. There we go. Okay. All right. This is obviously not a cardiac case, but I want to bring this up because we need to make sure that this is getting out and everybody's knowing it. Should be published by your agencies. It should be on your, whatever it is, your flash boards to see that how we want this. But pediatric trauma diversion. Transport all pediatric trauma entry patients to pediatric level 1 hospitals. That's Emmanuel or OHSU. Most of the time, if you're going from the field and you're entering into Portland, your destination will be Randall, because that's the catchment area. If they're going by helicopter, then they fall into the trauma system there, and they sort of alternate back and forth. But that's not your worry. Transport all to a pediatric level 1 unless the closest hospital is necessary for airway control, vascular access, or if the patient is in an arrest. For long transport or traffic issues, consider activating life flight. And either hospital has in Clark County has a helipad, which might be the closest place to do if you're in town, or, you know, okay, this coming weekend, I keep seeing signage all over that the Jackson Bridge is closed, which means, anybody remember the traffic in 1977 across the I-5 bridge before there was a Jackson Bridge? It used to take me coming to a night shift at Memorial or St. Joe's. It took me at least an hour to an hour and a half to get across the bridge to get to work from Portland. That was a normal day, and there's a lot less traffic in those days. So I'd say that with the I-5 may be a mess. So if you consider and your dispatchers should be able to help you with some of that stuff. And of course, bridge lifts are going to give a problem too, and on and on and on. But consider for long transport life flight. Now, here's the big thing: medical control at P South Southwest. Contact is not required anymore if you're transporting to Portland, if that's allowed by county operating procedures. So pediatric trauma admission is allowed by your county operating procedures now. You don't have to call. Document it in your chart and you're covered. Matter of fact, they want you to go. Okay. Also, burns, you don't have to call Southwest and bother them when you're taking a burn patient to the burn center. Also, pregnancy with multi-system injury would also be an automatic one, although you're likely to go wherever there's good trauma surgeons for that. Death in the field documentation. We sent out a thing to all agencies. There's been lately a rash of undocumented dead people, and I don't mean aliens. Undocumented death in the fields. That's not the way it works. You're supposed to document every patient encounter, whether they're alive or not. Now, your documentation can be quite minimal and stuff. So, but all patient encounters are recorded in an MIR with time and procedures documented. All non-resuscitation and termination of resuscitation will have a EKG strip, except for traumatic arrest or obvious death. And the obvious deaths are the typical obvious deaths, incineration, decapitation, etc. All conversation with medical control is documented, name, physician's name, etc. Law enforcement will be notified by the PIC on all cases of death in the field and document who you talk. If you contact the examiner, document that too. So document. But we need to know, had two trauma deaths, same accident. The people who were not killed are well documented. They were transported. I have no idea who these other people were. He must have looked at them. So, all right, case one, real case. Dispatch for low blood pressure. responsive to verbal stimuli, lying in a recliner in a residence with family present. Per family, patient was discharged from Good Samaritan Hospital ICU tonight at 1800 hours after having 3 stents placed. So we've got a history of acute coronary syndrome, and it was recently fixed, or allegedly fixed. Patient refused discharge to a SNF and chose to come home instead. Per the family, patient started fludrocortisone and midodrine, which is for blood pressure. It's an alpha agonist. And this was increased, and he took some more, he's taking it 3 times a day. They gave initial stuff that night because his blood pressure was low. They, should have had a sniff, but that's another. Slow to answer, able to answer appropriately. Stated that tonight he felt tired, weak, short of breath, dizzy, and had pain in his right shoulder. Stated his breathing was better now, his pain was gone, cool, dry, normal respiratory effort with increased rate, severe generalized body weakness, appeared uncomfortable, no other signs or symptoms noted. Transported code 3, a STEMI alert to PH Southwest. Unable to perform right-sided 12 lead due to demand pacemaker obscuring bass rhythm. Okay. Patient remained responsive, continued to deny pain and discomfort, etc. At destination, verbal report. Blood pressure, pulse 70, pulse ox 90, blood pressure's 90/70, blood pressure dropped to 82. Probably could have had a little bit of fluid if his lungs were clear. So here's the first 12 lead. Now, the machine says meets ST segment criteria. Well, indeed it does. Inferior. It also says the typical nonsense to these machines says possible anterior infarct age undetermined. That means it sees a Q wave somewhere. You can forget that stuff as a rule. It's got right axis deviation. We got down and up, so in AVF, so it's right axis. So that looks a little suspicious. Okay. Now, then as they're transporting, he goes into this pace rhythm, and of course all bets are off now, right? You can't do anything with that one, so just throw that away. And why do you throw that away? Well, oh, did you? Where's Mark? Did you put in the results? No, it doesn't come in here. Yeah. At any rate, I can tell you this one. So the problem was, so you've got this first one that shows ST segment elevation, and that's the one they called the STEMI on. Problem is, in the translation in the ED, the cardiologist saw the second one, didn't ever see the first one. And by that time, in the ED, his 12 lead had essentially normalized, it had gone back to the other rhythm, and he has ST segment elevation, but he'd been treated at Good Sam for an inferior STEMI with 3 stents. So he still had some ST segment elevation, which might be not good for him, but that's what, at any rate, this is then a really prolonged case after the fact. sort of wait a second on this one. Hmm? Yeah, I know, but I do want to get it because we got the other cases too. Because I reviewed all those cases. Well, let's go on to okay, this is a great case. 'Cause prior to arrival, Firecom advised the only entry point to the townhouse would be through an open window on floor 2. On their arrival, this is a large complex, and there were all the windows on floor 2 were open because it's hot. So they had to try to figure out through Firecom and the patient as to which door, which unit, which window, and the patient said she couldn't get to her front door because she was in too much pain and too weak. A neighbor said the right window, and so they crawled into the second-story window with a roofing ladder and made contact with the patient. However, well, they could see visual contact, but they couldn't get it through because the patient had a security rod in the window. So then she ambulated to the window, removed the rod, but couldn't do it. Allegedly too weak, I guess. The rod was partially removed with a halogen, whatever that is. Got to be some sort of I thought maybe it was a hooligan, which is another thing. Entry is made through a small opening in the window, and then firefighter went down, opened the front door, the rest came in. So arrived at the scene, and now this took a little time, obviously. Arrived at the scene in an upstairs bedroom of an extremely cluttered and poorly maintained townhome to find the patient laying right lateral recumbent on a bed. Patient is initially awake, loses consciousness, has agonal respiration, and loses pulse. Well, what an appropriate time. Patient has also numerous open sores on her face, and her pupils are 5 to 6 millimeters bilaterally. Cardiac arrest, rule out STEMI, possible drug overdose. So, primary assessment, CPR initiated, defib placed, metronome monitor set, paddles mode, due to witness arrest, rhythm assessed immediately, patient in VFib, charge accidentally dumped, CPR initiated again, monitor recharged, patient still in VFib, defibrillated, CPR immediately. Personnel have considerable difficulty making access to patient due to extremely cluttered residence. One additional engine, CPR continued, patient in VFib, defibrillated, CPR begun again. Remainder of personnel arrived with equipment, OPA placed. After 200 compressions, patient in VFib, defibrillated, CPR immediately resumed. IO placed, a milligram epi given, patient has purposeful movement and tries to push us away while doing compressions. Patient has pulses for approximately 15 to 30 seconds, observed to be in sinus rhythm, loses pulses. CPR immediately resumed. After 200 compressions in VFib, defibrillated, CPR immediately resumed. 300 milligrams of amiodarone given. After approximately 100 compressions, patient again has purposeful movement and yells. CPR stopped. Patient found to be in a narrow complex tachycardia, appears to be sinus at the rate of 145. OPA removed, patient's vitals 208 over 152. Heart rate 140, sinus tach, respiration 22, SpO2 97, responsive to pain and verbal stimuli after being aroused, states her leg hurts. She's having difficulty breathing. Lung sounds clear, equal bilaterally, egress plan formulated. Placed on a tarp, removed from upstairs bedroom, secured to a gurney, placed in the ambulance. Code 3 with 2 additional riders. 12 lead shows AFib with left bundle branch block, but ST elevation of greater than 1 millimeter in lead 2, 3, and AVF with concordance. Okay. AFib, And she has ST segment elevation and remember, concordance, upright QRS, ST segment elevation. Upright QRS, concordance. You only need one good lead to do that, to get that. So she has concordance. She's given 200 cc's of fluid during transport. Her blood pressure is dropping. Her blood pressure on arrival, blood pressure 98/70. And they were notified of STEMI activation. Here's another better picture of that 12 lead. How do you like those? Now, that's the second one. Now, oh my God, this is Camus. We've done another one. Actually, there were two more in there too. So, I'm not sure what I'm more impressed by getting access to the patient or picking out that this was a STEMI with, this was a Y complex tachycardia with concordance. The patient went emergently to the cath lab where she had a RCA occlusion, complete RCA occlusion, and she was stented. She also had moderate to severe left anterdescending and circumflex coronary artery disease, but those weren't the culprit lesions at this time, so that may be fixed at another time. You don't stent all of them at the same time. She's in cardiogenic shock after angiogram. Actually, she was in cardiac. But when she left the ED to go to the cath lab, she was at a pressure of about 70, even with pressors. So she went to the ICU on pressors, on 2 pressors, but was weaned off the pressors by that same evening. So it's not uncommon to, after a STEMI and then to the cath lab to get basically a shock heart, and it comes back very quickly if the STEMI is fixed. She's on metoprolol, low dose lisinopril, and her diabetes mellitus, her type 2 was out of control. She wasn't taking care of that. It was suggested she give up her drug of choice. It would also, her dermatologist thought that'd be a good idea too. And this is a perfect chart because it describes everything in perfect detail, including lots of good 12 leads, which make good teaching. Mark?
I don't have that. That one transferred over, but the other ones didn't.
I sent, well, I'm going to have to try to go by, okay. Okay, case 1, the one that we talked about, the gentleman who, okay, he had a very prolonged course, relatively prolonged course in the ED, which included a bunch of bad things. He ended up with a pneumonia and GI bleed and all sorts of stuff. And ultimately, the family elected to do comfort measures only. They got him into hospice. He was being found a hospice bed, and he died in the hospital before they were transported. Number 2. Now, this was one of the cases that the cardiologist said, well, this is not a STEMI, then we're not going to take this to the cath lab. Would I have called that one a STEMI? Yes, because of that first 12 lead. It's now, if you had more history, if you knew, the family was very vague about, they didn't know where he had, why he had it. They really didn't know why he had his stents. They really didn't know where they had his stents. other than at Good Sam. And they really, and this guy has a long, long history of COPD and coronary artery disease, and with those ST segment elevations and a guy complaining of chest pain and extreme cardiogenic shock, basically I would have called that one too. So that's not, in my opinion, a false STEMI. It's someone who didn't go to the cath lab. It's not the same. Number 2, 30 minutes ago, while at rest, she started having, quote, cardiac chest pain. States pain radiates to her jaw and left arm. Pain feels exactly like her 3 prior heart attacks. Well, that's a pretty good history of, and it makes you a little anxious. So you right away puts her into the acute coronary syndrome place. She's also experienced shorter breath. However, she's able to talk full sentences, clear and equal bilateral lung sounds. She's always on 1 liter oxygen at home. SpO2 was 90% of 1 liter, was bumped up to 4 liters, and SpO2 was now 98. Also complains of left leg pain that she's had since yesterday morning. No apparent abnormalities were found on that. Now denies physical chest pain, now, nausea, vomiting, dizziness, headache, blurred vision, etc. Due to tight quarters of residence, patient was assisted to recliner to a couple of steps outside her front door to the gurney. 12 leads showed elevation in lead 2 and lead 3 and depression in AVL and lead 1. During code 3, now, so that should give me a pretty good idea of where this is. During code 3 transport, fentanyl given, serial 12 leads were obtained. She does feel better. Blood pressure was declining, fluid bolus was administered, blood pressure improved. Transport uneventful, transferred care. Cardiac history of atrial fibrillation, COPD, pulmonary embolus, hypertension, etc. Got warfarin, or her medications are warfarin, oxycodone, trazodone, metoprolol, etc. So both for cardiac and respiratory. She was alerted for as a STEMI with suspected inferior leads, and this is the 12 lead on which they alerted her, which is not terribly exciting. Atrial fibrillation, looks like she has a left axis deviation, and she has arguably minimal ST segment elevation in these leads, and not so much this. The repeat 12 lead in the ED was of much better quality and did not have this appearance. Cardiologist compared both things and said, I don't think this is a STEMI. Said, I'm not going to take this one to the cath lab. Put her upstairs in the CICU, and she and her troponins bumped. She was quadruple normal the next morning, and they ultimately, and so she had a non-STEMI, and her 12 lead hadn't changed. Interestingly enough, possibly by treating her on the way in after with oxygen, high flow oxygen, and with the nitro and pain meds, you may have converted what was going to be a transmural infarct to just a subtransmural infarct or an STEMI. She went to the cath lab and she did have right coronary disease, and it was ultimately stented, even at her age. And she left the hospital and is doing fine. So, would I have called that one? Probably, but I don't think this was a missed call. This just was. This was a STEMI in progress, which was fixed, which is the way I'd like to see that done. Is, I'd rather have you overcall than undercall. Now this guy had surgery for valve replacement, coughing, felt a pop in his chest, then had severe chest wall pain. Well, that immediately makes you suspect that this is mechanical chest wall pain rather than ACS. So patient also was recently diagnosed with pneumonia, not currently on antibiotics, has not taken warfarin for his past 3 days because he, quote, unable to refill it. Patient states his pain is like his chest wall pain. It's worse with palpation, totally reproducible. He had a mechanical heart valve placed, has a productive cough, also some dizziness, shortness of breath, and nausea. Sitting outside his facility on a 4-wheel walker, was given some nitro, transported, code 3, en route given pain meds, STEMI alert because he has elevation in 2, 3, and depression in V2 and V3. Handoff. Okay. So here is his. So he's got ST elevation. He doesn't have. He probably has some right ventricular hypertrophy. He's definitely got left axis deviation. He's got fairly wide complexes, but not wide enough to, and it's not a left bundle branch pattern. So the question is, would we call this 2, 3 and AVF? I think yes. I would have liked to see. Did we do a? I don't see a V4R. So this was called as the STEMI. The cardiologist came in, evaluated him, and once again, the 12 leads in the department were not as impressive as this. His chest x-ray indicated pneumonia. He did not have evidence of a PE. They did a CTA. Cardiologist determined that this was more than likely just chest wall pain from his recent surgery and maybe pneumonia. Did not have a PE. He was observed. He did fine. He had no troponin elevations. Would I have called this one? Probably yes, with what you've got here. Now this might be one of those cases where careful placement of the leads. And if you thought this was an inferior MI, I would really wanted to see a V3, V4R as well. Priority 2 for chest pain. Patient was sitting on the couch relaxing when she complained of pain across her chest, feeling like a constricting band. Had this sensation before, unable to explain further. Has a history of chest pains, been diagnosed with the normal abnormal EKG. Whatever that means, right? Unable to explain what is normally abnormal. Patient denies secondary complaints aside from shortness of breath, has a past medical history of insulin-dependent diabetes, CVA with gait abnormality, hyperlipidemia, asthma, and depression. 52-year-old, that's a lot of things to have when you're 52 years old. 52-year-old female, constant alert, chest diminished but equal expansion, lung sounds are clear, abdomen soft, non-tender, vitals 150 over 82, 71 heart rate, 16 respiratory rate, O2 is 96%. 12 lead EKG, so normal sinus rhythm with 1 millimeter ST elevation in leads 2, 3, AVF, and V4R without elevation. Assist patient to stand, pivot to gurney. Chest pain doesn't increase with ambulation. Got some nitro spray. Pulsera arrived at Southwest Medical Center, transferred patient to RN without incident. So this was her initial 12 lead, so very minimal anything in that one. Say minimal in that one. Well, so what happened here? So I'm hard pressed to find any significant ST segment elevation in this. There's slight suggestion in AVF, slight suggestion in, well, that's it. And there's a Q wave in 3 AVF. It makes me think that this is what he's talking about, the normally abnormal. She just has an abnormal 12 lead, and I'm not, and this probably should not have been called as a STEMI. I don't think there's enough ST segment elevation here to buy anybody anything. So of all the cases, so we've got 5 cases, one of which we incorrectly called a STEMI. Now, last month was quite nice because this report from the hospital, they had no false STEMIs whatsoever last month. Usually the most false STEMIs they get come from the other hospitals. They're miscalled at the hospital. Marty can attest to that. That's what they usually come in there's a high incidence of false STEMIs that come from the referring hospitals. So when you get, like, if you get the Pulsera report that shows that you, in the first couple of cases, you would have called the cardiologist or triggered the STEMI. The way the Pulsera works is the ED doc looks at that, and if they concur that this is a STEMI, we would normally call a STEMI, right? So I know at least in 2 of those cases that the cath lab was triggered based on those, and then it was then shut down by the cardiologist. Said, no, I'm not going to take this one to the cath lab. In your experience, how often are you getting a STEMI call from the hospital, from the EMS that you override?
It happens. I mean, it's not common, but it does happen. A lot of times we have the advantage because we have historical EKGs compared to baseline abnormality.
Right.
Pre-existing history.
Yeah. And that's another reason why with the Pulsera it's really nice if you have the patient's driver's license, or if you have their Medicaid, Medicare identification cards and all that, if you can take a picture of that and send that with the pulsar, then he can get into their cardiac, their hospital records, which if they've ever had a 12 lead there, that's all stored in the Muse, so he can compare that immediately to get that up. If we don't know who the patient is, you can't do that until they arrive, so that delays that.
We had a classic one the other day that was actually came from triage. We walked out private vehicle arrival, and it was a guy that had pre-existing left bundle or wisdom back as a possible STEMI from triage. But I quickly looked at the record, and it was identical to his previous EKG. So he had a calf that was done in 17 as you were in the normal coronary arteries.
Yeah.
Instead of activating the whole cath lab team, you could prevent that and work on it.
Yeah, one of the other, on that, and what you wouldn't be aware of historically, and why it's nice to get the record, the case that I talked about that he'd had a valve just recently, and so he was still post-op the valve. What you don't know, or what you don't think about, is that we know that guy has clean coronaries, because before you get a valve job, you have to have a coronary angiogram, because they have to fix the coronaries. There's no point in fixing the valve and having him die of a coronary, post-op or anything. So they always do. So we knew the guy had, a month ago, clean coronaries. So that also gives the cardiologist the idea that, oh gee, I'm not really excited about this 12 lead. He just had surgery and he's got this and that, but we know he's got clean coronary. You can't develop coronary artery disease if you've got clean coronaries the month before. It takes a couple more hours than that. Okay. Well, I'm sorry we missed the absolute follow-ups on that, but that, to the best of my recollection, is exactly what happened to those people. Okay, thank you. It seems to be a good time to quit.